Dr. Sharsoor, sir, open your PowerPoint on the desktop
Now we can share it.
and then share the screen, sir.
Okay, अच्छा मैम एवं सैचुरेशन कितने अच्छे सिस्टम लास्ट कितना लिखा
It's visible? No.
So you got the share screen option.
Yeah,
The
that
bottom.
is there. That is
Okay.
there. One participant can share. Or shall I re-log in once again? I'll try and re-log in once again. I think.
Sir, no need, sir. Just I'll guide you 2 steps, sir. Open up the PowerPoint on the desktop, sir.
Yeah.
Is it open on the desktop, sir?
Yeah, it is open.
Okay. Now press the green screen, sir.
Yeah. Desktop 1.
Share screen and click on that.
Share.
On the share screen, you click the green button and then click on the PowerPoint.
You click on the share screen, what you're getting, sir? If you click on the share screen, what do you get?
See, one at a time or multiple.
No, you forget about that. Only click on the share screen.
Yeah, desktop 1.
Click on the desktop one, sir. Click on the desktop one, that's all.
It's not opening. I will do
It just came and went. Click on the desktop 1.
Coming?
Okay, now you try once again, sir. Only click on the green button, share screen.
Correct.
Click on the desktop you are getting.
Allow Zoom to share your screen.
Yes.
Grant access. I think there is, I'm having some.
It had come sometime before.
Alle first ಬರೋದು ಶಿವಾನಂದ್ ಅವ್ರ ಮಿನಿಸ್ಟರ್ ಮನಿ ನೆಕ್ಸ್ಟ್ ಅದ್ರ ಬಾಜು ಹಿಂಗ್ ದೊಡ್ಡ ಪ್ಯಾಲೇಸ್ ಕತೆ ಕಾಣಿಸ್ತಲ್ಲ ಅದೇ ಶಿವಶರಣ ಅಂಕಲ್ ಮನಿ
Sir, I will make you host.
make him forced to share, allowed to share the screen.
ನಮ್ದು ನಾವು ಮೇಂಟೈನ್ ಮಾಡ್ತೀವಿ
Shall I share my slides, Bhaskar? That will be better, it looks like.
Yes, sir. That also you can do. And meanwhile, we are made co-host also. It will be easy, sir, actually.
But it is having some difficulty. I will do one thing.
You can send it, sir.
Immediately it will be.
Okay, surely.
Just see, I have sent it now. Yeah, it is gone.
This is Dr. Harsha Kulumbrikar here.
Just see, Bhaskar, whether it has come.
Just it has come.
Sir, Dr. Harsoor,
Yeah.
maybe you could put off the other devices that are working on the same Wi-Fi right now. Maybe your mobile could be put on a 4G and
No,
other.
I am not using mobile.
Sir, is there any other device which is using your Wi-Fi at the same time? That is the commonest problem there.
At present, there is no other
No other device?
in the house also.
Achha, okay, okay.
Sir, you can see my screen.
Yeah.
I will project, sir. As you say, whenever I will advance the slides, sir.
Yeah.
Okay. So sorry to all the viewers also. Sorry to sir for the technical hitch. Over to you, sir.
Okay. So thank you very much. I think we have already lost a precious few moments. First and foremost, let me wish the happy Krishna Janmashtami to all the audience present in India and across the world. And at the outset, I would like to immensely thank the organizers of this program, headed by Dr. Muralidhar Joshi, our ISA president, Dr. Naveen Malhotra, our secretary, and Dr. Bala Bhaskar, who is our academic coordinator, including Dr. Venkatagiri, who is a very active person involved in that. And I could see some of my senior colleagues like Professor Agnihotri and others. Thank you, everybody. Let me begin the talk with the first topic, that is the anesthesia for a laparoscopic surgery. Next. Next slide, please. Yeah, these are the topics what I'm going to cover: introduction and history, and what effects it produces, the pneumoperitoneum and the position, that's most important. And then we'll move on to anesthetic management and post-operative management and other things. Next one. First and foremost, what we need to remember is minimally invasive surgery is not a minimally invasive anesthesia. Anesthesia is a full-fledged always. There is nothing like a minimally invasive one. Next one. Historically speaking, just one sentence I would like to say. It was the first time in 1901 a killing performed the inspection of the viscera of the dog, and that's how he saw the laparoscopy. And then the laparoscopy gained its importance when in 1989 Reddick and Olsen, when they published their study of comparing 200 laparoscopic cholecystectomies with the then popular mini laparoscopy. So after that, then the importance of the laparoscopic cholecystectomies went on steadily. And now it is well established that there are several advantages. Next one. there are several advantages for doing these laparoscopic procedures. That is, the first and the foremost is the stress response. That is, the decreased metabolic response such as hyperglycemia and leukocytosis is very obviously seen in these surgeries. And there is a better nitrogen balance, better preservation of the immune system. And what is obviously seen is the acute phase reactant, that is CRP and IL-6, which are indicators of the tissue damage. They are not increased significantly when we compare the same thing with the open cholecystectomies or open laparoscopic procedures. And other advantages include the endocrine response like urinary VMA, cortisol, and albumin levels are not much different from laparotomy. Because there is another advantage is it avoids the intestinal handling and reduces the peritoneal irritation, because not much of the manipulation will be taking place. And ultimately, it is the reduced hospital stay which has really attracted the attention of many of the surgeons and the other people. And also, there is a significant reduction in the post-operative pain when compared to laparotomy pain, because all that the patient will be having is only about a dull aching pain of visceral origin instead of sharp cutting, parietal pain, and the pelvic spasm that was seen in the laparoscopic procedures. And if at all, there will be a mild degree of a shoulder tip pain, and this also can be obviated with the help of a slow and complete evacuation of the residual carbon dioxide rather than squeezing the abdomen trying to push it out. And some of the surgeons even allow an abdominal drain to be kept for the carbon dioxide to escape, so that this post-operative shoulder pain also is minimized. What are all the insufflating gases that we use in these patients? Next one. Let me begin with one question for our audience, especially my postgraduate colleagues. They can answer these questions in the chat box, and ISA, the national body, has made arrangements for awarding the earliest persons to send the answers in the chat box. And the first question goes like this: which is the good non-combustible gas used for pneumoperitoneum? The best one, which is that? A, oxygen, B is carbon dioxide, C, nitrous oxide, and D is the air. Say about 10 seconds time. I think this is the commonest, probably the easiest question. Okay, so B, I think most of the answers are coming as B, right? Okay, CO2, right, next one. So the answer is correct. That is, most of you have answered correctly. That is a carbon dioxide. I will go into that details, what it is, in the next few slides. Air is the one which has a low blood gas solubility coefficient of 0.016. But the problem is it supports combustion. So because thereby the use of cautery should be avoided. Otherwise, it will not be possible. The explosion chances are high. And also, the chance of air embolism, should the air enter into the vascular system, the chance of air embolism are much higher. And also, as I said, because of its poor absorption capability, the post-operative shoulder pain also is very high, thus making air as a poor choice for insufflating the laparoscopy, during the laparoscopy. Next one. Oxygen also can be used, but the major hazard once again here is the explosive nature, because it supports the combustion. So hence the cautery cannot be used. And these days, we cannot do any surgeries without the cautery. And here the blood gas solubility coefficient, it is a 0.03. So therefore, once again, the higher incidence of gas embolisms. So accordingly, this also will not be a suitable gas for the insufflating purpose. Can we use nitrous oxide? Because it has got a few advantages, like it cannot produce a hypercarbia and the incidence of arrhythmias will not be there because of this. But once again, this also has got a moderately low blood gas solubility coefficient of 0.47 only. And the minimum shoulder pain is possible in this particular thing. So next one. But the disadvantage of this is it supports the combustion, and definitely this combustion capacity is much more than the air. And by any chance, if there is an injury to the gut or where the gut surgeries are conducted in such a situation, any of the methane that is released, there is a possibility of once again intraperitoneal explosion. So therefore, nitrous oxide also may not be a very good gas for the purpose of insulin. Next comes our commonly used carbon dioxide. The reason is it is very easily available and non-toxic. And it has all the excellent properties like non-flammable. Early pulmonary excretion is possible because of its soluble nature. And the blood gas solubility coefficient is pretty high. That's a 0.8. That is almost about 20 times more soluble than air. So therefore, even if a small amount of gas enters into the systemic circulation during any time, the minimum incidence of embolic clinical picture will be seen. But the only disadvantage that the carbon dioxide poses is a possibility of arrhythmias, because that too, when the carbon dioxide PCO2 levels go high up and acidosis is seen. Otherwise, the arrhythmias are not a common thing. The other things that are used are helium. Helium has got a very poor blood gas solubility coefficient and a high incidence of gas embolism. So it is mentioned only to complete the list. And the next one is like the gasless laparoscopy also is being tried. It was tried earlier. What they do is using a fan-shaped retractor is inserted and abdomen wall is lifted. But unfortunately, it does not give a good surgical exposure. Hence, it did not become very popular in the days to come. So therefore, carbon dioxide ultimately becomes a best choice because it is safe and also the chance of arrhythmia or other complications are less. And should the gas enter into the venous system, the chance of manifestations of a gas embolism also are very minimal. So let us see, the major difference here is the pneumoperitoneum. That is the one what we are inducing to perform the surgeries, and also added to that is the surgical positioning. So therefore, we'll begin with the question number 2. Which of the following is not true? Not true, please note. In the following a pneumoperitoneum, that is, first one, closing volume is increased, airway resistance is increased, thoracic compliance is decreased, shape of the pressure volume loop is altered. Okay, the answer is already shown by the this thing. Some people are still thinking that closing volume is increased. No, that is not the correct one. Thoracic compliance is decreased, airway resistance is increased, closing volume is decreased. What is not true is shape of the volume, pressure volume loop is not altered in this. That I'm going to tell you in the next few slides. So the effects on the respiratory system because of the pneumoperitoneum and also positioning is the moment pneumoperitoneum is created, the diaphragm gets elevated, and this reduces the functional residual capacity, and thereby the closing volume is increased, and ultimately it leads on to increase in the ventilation perfusion mismatch and with the clinical manifestation of hypoxemia. That is the ultimate thing that happens. Okay, next one. So what actually happens is the airway resistance is increased and the thoracic compliance is almost reduced by about 50% in some instances. But what is important is the pressure volume loop is not altered. This is the answer to the previous question. The shape of the pressure volume loop remains same. You can see in the image here. Next one. You can actually see how a loop, pressure volume loop, before the pneumoperitoneum is created, the blue one, you can see that. And what actually happens, next slide please. What actually happens after the inflation with 14 millimeters of mercury and a head up tilt of about 10 degrees, how the compliance comes down, you can actually see, next one, before what was the compliance was 56 ml per centimeter of water has come down to nearly half, that is 27 centimeters of water, ml per centimeters of water. So that is how the compliance is brought down. That is a very significant one. That has to be kept in mind. And with regard to hypercarbia, because the carbon dioxide is used for creating the insufflating. Bhaskar, there is a little bit of a noise. I think you can mute all the other people.
Yeah, I request all participants, the viewers, to please mute themselves once again. Give me a moment. I will just mute everybody, and then you please unmute yourself. Yeah. I think everybody is muted. Okay. Yes,
So,
sir. Sorry.
the other effects that are seen on the respiratory system include, one of the important thing is hypercarbia. So what happens is, following carbon dioxide insufflation, the carbon dioxide, the PaCO2 level progressively increases and it reaches plateau by about 15 minutes. So first 15 minutes, we can see gradual increase in the PaCO2 levels as well as the EtCO2, what we see on our capnography monitors. That is, it is proportional to the intra-abdominal pressure when the pressure is below 15 millimeters or 14 millimeters of mercury, what is commonly used. But in the event of the surgeons using an intra-abdominal pressure of more than 14 to 15 millimeters of mercury, what happens is the peritoneal circulation that is there, that gets compressed. And because of that, the rate of carbon dioxide absorption relatively drops. So therefore, it is only seen for the first 15 minutes when the pressure is below the 14 or 15 millimeters, what we commonly use. Next one. You can see this image here. The yellow one, this is what is seen in our carbon dioxide capnogram monitor, and the pink one, what is actually the PaCO2 that the patient is having. So you can see the first 15 minutes it is rising, and the difference almost all the time it is about 2 to 6 millimeters of mercury. The gap between the PaCO2 and what actually we see in the PtCO2 on the monitor screen will be about 2 to 6 millimeters. But what is important here is, say about next about 30 minutes or so, the pH of the blood will remain almost static, but beyond 30 minutes of time, the pH starts becoming acidemic. You can see that it is by 45 minutes, it has already come down to 3.4. So therefore, though the clinically it is visible that the difference between this PaCO2 and EtCO2 are about 2 to 6 millimeters, it is very difficult to predict it. Next one. So due to lack of this consistency, the pH keeps on dropping, and the gap, though it looks on the screen, it is the gap only is about say 2 to 6, but there is no consistency. So therefore, intraoperative EtCO2 monitor should be used as an estimate with only caution. When everything is clinically all right, it is good. Otherwise, you have to fall back on other things like measurement of the pH and other things. Next one. And of course, these days, under local anesthesia, the surgeries, the laparoscopies are not done. But if it is done for any reason, the natural body mechanism will get compensations, that is respiratory rate and the minute to ventilation automatically increases and the PaCO2 is kept normally. And of course, once again, the general anesthesia with the spontaneous ventilation, these days it is not practiced. We used to do it earlier. But in case if it is done, here the disadvantage is the increased work of breathing, because I already said there is a compliance is reduced, and also anesthesia induced respiratory depression will be there, and therefore the spontaneous ventilation is not a good choice when the pneumo is created with the carbon dioxide during laparoscopic procedure. Added to this will be the pre-medication that we have given that also can contribute to the respiratory depression. So therefore, the PaCO2 is likely to go up if we are using a spontaneous ventilation. Next one. Next. So the rise in the PaCO2 and EtCO2 is naturally, it will not be seen if nitrous oxide or helium are used as insufflating agent. In the sense, what I want to say is the rise in the carbon dioxide VaCO2 levels are solely because of the pneumoperitoneum that is created by using the insufflating gas, that is the carbon dioxide only. Next one. And also there are right now, to fall back on the EtCO2 as the guide for our PaCO2. There are no published studies that have confirmed the relationship between the duration, after what time the carbon dioxide pneumo, the intraoperative hypercapnia and acidosis will become clinically significant. There are no such studies available. So therefore, it is not advisable. And it is better we maintain the PaCO2 within normal limits by increasing the minute ventilation by providing a good muscle relaxation. And what we should keep in mind is when we change the position, most of the pelvic procedures, the cephalad movement of the carina and the diaphragm will be there due to increased intra-abdominal pressure, and therefore there is a possibility of endobronchial intubation which is exaggerated in the head-low position. So therefore, next one, we must always confirm the position of the endotracheal tube once after the pneumoperitoneum, and also once again you check it if the steep head-low position is given like in the uterine surgeries or the prostatic surgeries. So these are some of the important respiratory mechanics and the changes that are seen during in the respiratory system. As far as the cardiovascular system is concerned, an intra-abdominal pressure of up to about 5 millimeters of mercury during the pneumoperitoneum may not have any significant effects. But once the pressure crosses, say, about 10 to 12 millimeters of mercury, there is a subdiaphragmatic narrowing of the inferior vena cava. The inferior vena cava gets compressed because the pressure will be, most of the times it is less than 10 millimeters. So that gets compressed. And also there is a compression of the venous capacitance and the arterial resistance vessels will be seen. Next one. And next one, please. Next. Can you move the slide, Dr. Bhaskar? Hello. Hello. I think it looks like we have lost the connection. Just we'll wait for some time. Okay, so we are back here. So I was just telling the intro, yeah, just back the previous slide, please. When the intra-abdominal pressure, it crosses 10 millimeters of mercury, because of the diaphragmatic narrowing of the inferior vena cava, there will be also the compression of the venous capacitance vessels and the arterial resistance vessels are also seen. So ultimately what we see is both the pulmonary vascular resistance as well as the systemic vascular resistance is increased. So it will be clinically manifesting as increased mean arterial pressure. Most of the times we will be seeing it. And during the initial phases of this pneumopericardium, there may be pneumoperitoneum. I'm sorry. There will be initial preload is increased and the afterload is increased, but the cardiac output remains unaffected in the initial first few minutes. But later on, the preload may decrease and the cardiac output may also come down. In addition to that, there will be decline in the left ventricular function, and the cardiac index is reduced by as much as about 30 to 40%. And this increased central venous pressure and the pulmonary artery occlusion pressure due to incidental high intrathoracic pressure forces the blood out of the inferior vena cava and the abdominal organs. And what we see is a prominent peripheral pooling of the blood that is taking place. And in addition to that, we may see the bradyarrhythmias, but most of the bradyarrhythmias are due to the needle insertion. There is needle insertion or the sudden stretching of the peritoneum, especially under light planes of anesthesia, or sometimes, occasionally, it may be because of the minute degrees of carbon dioxide embolism. But otherwise, normally the bradycardias are not related to the cardiac, carbon dioxide pneumoperitoneum. And one of the beautiful systematic review of 34 articles spread over 20 years, they have found that the tachyarrhythmias are most common because of the high PaCO2 levels and the catecholamine release. Especially this is seen in patients with COPD undergoing the laparoscopic surgery. This is one of the Indian publications, one of the excellent reviews what I came across. Next one. Even the liver also being an intra-abdominal structure is affected because of the increased intra-abdominal pressure. The hepatic and the supramesenteric artery blood flow is decreased. The portal venous flow is increased. And there will be a transient elevation of liver enzymes. There will be a very mild one. The CRP and the IL-6 are much less elevated when compared to the laparotomy. Next one. And there will be increase in the ADH secretion, the aldosterone and the renin secretion will be there. So with the result that there is a decrease in the both the cortical as well as the medullary blood flow. And ultimately what happens is the glomerular filtration rate and the urine output as well as the creatinine clearance are decreased. And in some of the sensitive patients, this may become an important issue, should be kept in mind. And central nervous system as such, the cerebral blood flow is increased, but the intracranial pressure may be increased, and this can be independent of a pneumo also. Without the carbon dioxide pneumo, also the increased intracranial pressure can be seen, especially when the position is being changed. Next one. And other gastrointestinal structures, there is a higher incidence of a regurgitation and aspiration of a gastric contents, especially in the steep low position. But this is not always supported. There is a lot of controversy about this particular statement. But one thing is important, that is a post-operative nausea and vomiting is significantly high. As much as about 40 to 75% of the patients we will be seeing a post-operative nausea vomiting, which needs our attention. Next one. And I earlier told you, because of the inferior vena cava compression, the femoral venous blood flow is reduced, and there will be pooling of the blood in the lower limbs, especially in the head-up positions. And there is in a prolonged procedures, so when there is a possibility of a DVT also because of this venous compression, and this must be kept in mind. But when there is a prolonged head-low position, although these problems are minimized, the intraocular pressure may be elevated, and this can even lead to visual loss. This was one of the things that I came across in the article, 2015 article. So we cannot just ignore the fact that the intraocular pressure also can go up, and that should be kept in mind. And these patients, often the positions are changed and the surgeons will be working around in various positions. So brachial plexus injury is a thing that is a possibility because of the overextension of the arm and wrongly placed shoulder places to prevent the patient from sliding down during the positions. And lower extremity compartment syndrome is another one which can occur, especially during the prolonged procedures, and the peroneal nerve is highly vulnerable. So therefore, it is always preferred that arm by the side of the patient is the most preferred one, and any intravenous lines or other monitoring lines should be taken from there. Probably will provide some kind of a protection against these possible nerve injuries. And only because of the patient position, in the absence of a carbon dioxide pneumoperitoneum, a simple head-down position also can decrease the pulmonary compliance, and the FRC and the total lung volume both are reduced. And in a spontaneously breathing patient or a conscious patient also, the work of breathing will be increased and atelectasis can occur. And these are more importantly seen in elderly and obese patients. So whenever we add a pneumoperitoneum to it, these things get further worsened. So that has to be kept in mind. But the contrary is true when we are doing the procedure in a head-up position, because there will be a minimal improvement in the pulmonary dynamics, and the reduction in the FRC and work of breathing may not be a significant one. So how do you manage these cases? They come for the anesthetic management. So before we begin with that, I will be just asking another third question. Patients with a VP shunt or a foramen ovale, these will be having the right to left or left to right cardiac shunts and the VP shunt. The answers are true, or is it a relatively contraindication, or it is false? Are they contraindications for laparoscopic procedures? Okay, A, B, B. Okay, go to the answer. So it is a relative contraindication. How and why I'm going to answer in the next few slides. As far as the pre-anesthetic assessment is concerned, a routine pre-anesthetic assessment, like any other case, is essential, and it is the same as that for open laparotomy, because we have to assume that all these cases may end up in a laparotomy, although that incidence has come down. And consider the cardiorespiratory functional status as well as the comorbidities in view of the usage of this increased intra-abdominal pressure, as well as the positioning. I told you what will be there. And some of the people, especially the elderly patients, the surgeons think of doing a preoperative stress testing. That routine stress testing may not be required as per the published reports. Only in a selected cases we can think of doing this stress testing. And patients with a left to right shunt, there is a possibility of a paradoxical embolism, and especially in patients with advanced pulmonary disease, the FEV1 and the ABC may get altered. And obesity, at one time it was thought that it may be a contraindication for conducting these laparoscopic procedures. It is no more a contraindication. In fact, it is a preferred method of procedure in the obese patients. And another relative contraindication is a hypovolemia. We call it a relative contraindication because there is a theoretical possibility of a reduction in the venous return and the cardiac output because of the compression of the inferior vena cava. So therefore, it is better to exercise some kind of a caution in cases like, for example, a ruptured ectopic with intraperitoneal bleed or bleeding intra-abdominal injuries. In such situations, we need to exercise a little bit of a caution. And patients with the glaucoma, I told you earlier, the carbon dioxide pneumo may not have a significant effect on the intraocular pressure, but the positioning, if we employ a steep head-low position, in such situation, the intraocular pressure may increase. So therefore, we need to exercise caution. I don't call it a relatively contraindication, but then we need to exercise some kind of a caution. And we need to consider during the pre-anesthetic assessment itself, the prophylaxis against the possibilities of deep vein thrombosis occurring. As far as the pre-medication is concerned, the allaying anxiety is important. Drugs like midazolam may be beneficial, and prevention of aspiration of the stomach contents, we can use prokinetics. And then I told you earlier, the incidence of a PONV is very, very high. So best is to use some kind of a antiemetics like ondansetron or any better ones. And the use of anticholinergic, atropine, is a little controversial. Whether it is beneficial or not is doubtful, and it is left to your discretion. But these days, what we have found is the use of dexmedetomidine has gone up significantly, and it is found to be a very, very useful and excellent adjunct during the conduct of these laparoscopic procedures. What are all the monitoring tools that we require in these patients? The first and the foremost, we cannot afford to ignore the stethoscope, because the simplest thing is we need to check. I told you earlier, once the pneumo is created, we need to check the endobronchial position possibility is there. And also, if we change the position, especially head-low position, we need to check it once again. And the ECG is useful for the purpose of detecting any kind of arrhythmias, including tachycardia and bradycardia. And in case of the appearance of any micro voltages, it indicates the possibility of a subcutaneous emphysema or pneumomediastinum. These things I'm going to tell you next. Or there is a possibility of an axis change because of the change in the position of the patient. And pulse oximetry, yes, it is a useful one. But then, yes, desaturation in any complication is a very late sign. For example, in a gas embolism or pneumothorax, by that time, a lot of damage would have happened. But however, we cannot afford to ignore pulse oximetry. That's a very, very useful one. And the insufflator will be having a built-in intra-abdominal pressure monitor also. And that is necessary. The monitoring of the pressure is necessary to avoid the rapid rate of insufflation. I told you earlier, the possibility of bradycardia is high. And also, we need to avoid the high pressures, that is intra-abdominal pressures, because I told you earlier, this hemodynamic and respiratory physiology may suffer. So therefore, that is also an important monitor which should be under our vision. Next one is neuromuscular monitor. I know many centers may not be having it, but then it is an excellent tool which is very, very essential because it helps us in providing a good lateral lift so that a better visualization and the good surgery with the minimal manipulation of the organs or the intra-abdominal structures. And what we should remember here is a good relaxation is required till the end of the surgery, and immediately at the end of the surgery, they will be putting just 2 stitches and take out. So we need to really monitor the neuromuscular block so that there is no decorization effect will not be there. So that way it is a very, very beneficial one. And with regard to the temperature monitor, yes, frequent cold saline wash, because we never use a warm saline for irrigating the intraperitoneal purpose. And this becomes more important, especially in children or in prolonged procedures. And also prolonged use of unheated insufflating gas may have some effect, but it may not be a significant one. But cold saline definitely is a useful one. So these are the common monitoring systems that we use. And question number 4, which of the following is incorrect statement about capnography used during laparoscopy? Number 1, PaCO2 and PETCO2 gradient is always 2 to 6 millimeters, less than 2 to 6. PaCO2 may be underestimated by PETCO2. Sudden reduction in the ETCO2 indicates obliterated pulmonary circulation like gas embolism. Reduced ETCO2 may indicate low cardiac output. Please note incorrect statement about capnography. Okay, everybody, I think so far have answered only D. One person has answered A, D, D. Okay, please note the answer A is not always less than 2 to 6 centimeters. I told you earlier, it is not a reliable one. It may not be only 2 to. Next one. It may not be always 2 to 6. It can be much more than that, especially during the prolonged procedures. Prolonged anesthesia with the controlled ventilation, the gradient may reach almost 10 to 15 millimeters, and it is not necessary that it should be less than 2 to 6 millimeters. Remaining other things were correct. And patients with the impaired respiratory function, I told you earlier, the PaCO2 is grossly underestimated by ETCO2. So we need to confirm with the ABG these things. Next one. And other uses of a capnometry during the laparoscopic procedure. There is a minimal, even when there is a minimal carbon dioxide embolism, which happens quite often, there is a rapid rise of few millimeters of carbon dioxide, and quickly they return to the baseline because it's rapidly eliminated from the bloodstream. And some of the procedures, there will be extraperitoneal insufflation will be done, like in the renal procedures or during the hernia procedures where the peritoneum is breached. In such situation, there will be a gradual and the persistent rise, and sometimes it continues for several hours even after the completion of the surgical procedure. That has to be kept in mind during the procedures like hernia But what is important with the capnometry is a suddenly reduced ETCO2 indicates a reduction in the cardiac output, reduced cardiac venous return due to the obliterated pulmonary circulation or gas embolism. This is sudden and persistent reduction in the carbon dioxide, or sometimes it may be a modest increase followed by the sudden reduction in the EtCO2, sometimes touching zero. That is because of the air embolism, that is, or gas embolism, carbon dioxide gas embolism that has taken place. So therefore, capnometry is one of the best and unavoidable tool as far as the laparoscopic procedures are concerned. And esophageal stethoscope, if it is there, it is definitely useful, because we can even listen to some of the murmurs that can occur during this particular thing. Next one. And some of the invasive monitors. Yeah, whether the CVP is required. CVP, if we want to use it for the purpose of measuring the CVP, measurement is difficult when we are changing the position of the patient. And also, in addition to that, the varying intrathoracic pressure. Suddenly, if they apply the suction, the intrathoracic pressure steeply drops and then again picks up. So therefore, a CVP measurement may not be a useful monitoring purpose. One. And if you are using Swan-Ganz catheter, it can be used for the purpose of measuring the blood pressure as well as the ABG measurement, especially in high-risk cases. But the Swan-Ganz catheter is potentially a dangerous and an expensive job, and therefore it may not be a very useful tool as far as routine purpose is concerned. Although it is helpful to measure the early increase in the pulmonary artery pressure, which is a sign of a gas embolism. And also it can be used to aspirate the gas bubbles that occur following the gas embolism. But the thing is, as such, I told you, the gas embolism is much, much less a severe complication. I have not seen one case till this day. So therefore, whether you use CVP and Swan-Ganz catheters is really a matter of only a theoretical discussion. Next one. And some of these things, PE can be used, transthoracic electrical bioimpedance or pulsed Doppler velocimetry. Probably these are the things which are likely to have some kind of a future, because as and when they become more frequently available, probably we may be able to use these monitors also. So therefore, these are some of the, next one please. These are some of the commonly used monitors. What is routinely used, in addition to that, the capnogram will be more than sufficient, and CVP and the Swan-Ganz catheters may not be routinely required in normal ASA 1 or 2 patients. Only in high-risk patients, maybe its indication will be there. So that is with this knowledge of the physiological changes, the preoperative examination, optimization, pre-medication, and the monitoring. Let us now proceed on to the anesthetic technique. What technique can be used for this purpose? So before we proceed with that, we should know what are all the things can happen during this, what precautions we need to take. First thing is the prevention of visceral injuries. For this purpose, we need to deflate the stomach with the Ryle's tube, or if we don't try to ventilate these patients, nicely you pre-oxygenate completely for 3 minutes or more and then directly go for intubation. Or if it is the stomach is appearing to be distended, you will need to deflate it, and the bladder should be emptied either by asking the patient to void the urine or by passing the catheter. And prevention of nerve injuries, I already described, that is very, very important. Protecting the eyes from abrasions and compressions, because especially in the head-low positions, if you cover the patient completely, we may not notice it. So it is very important to take care. And we should not forget to fasten the patient to the OT table when we think that we are trying to change the position of the patient, either a side-to-side tilt or head-low and head-up positions. And remember, to give a head-up or a head-low position, the tilt must be a slow and progressive, not exceeding about 10 to 15 or 15 to 20 degrees, so that the sudden movements may sometimes lead on to ET tube displacement. So we need to be a little slow. These are the things we should keep in mind before we start the anesthetic procedure. Next one. Which type of anesthetic technique is good? There is no consensus concerning any particular technique. And because no specific technique seems to play any major role when you think of a patient outcome. So therefore, all the techniques are open depending on the situation. We need to take a call in this. Next one. But what should be our goals of anesthesia? Must be, one is smooth induction, needless to say, and the importance of a good relaxation. I'm going to stress upon this in the next few slides, and a quick recovery, which I told you earlier. And ultimately, the purpose of this laparoscopic procedure is early discharge, and that goal should be achieved or it should not be defeated. So these are the 4 important goals. And talking about the techniques of anesthesia, under general anesthesia, we can either use TIVA, which some of the consultants are very much popular among few consultants, and also we can use inhalational anesthetics. Both are equally popular. So also is the endotracheal tube, which is normally used. And these days, some of the articles are appearing with regard to the use of supraglottic devices like 2nd generation or 3rd generation, like Procelial MA or Buscamas, or regional anesthesia. Let's see what are these techniques that we can use. The basic purpose of this TIVA is avoid the use of inhalational anesthetics. So what they do here is oral pre-medication, it is done. And the induction and the maintenance is done with the help of propofol and remifentanil, which is a short-acting analgesic, a very good analgesic. And intubation is facilitated by neuromuscular blocking drugs. And unlike using the inhalational anesthetics to deepen the plane of anesthesia, here we use more of a remifentanil and these analgesic drugs. And here, one of the benefit is the anti-emetic property of the propofol. Next one. And this particular study, what I am showing, the Renman and others, published in 2001, long ago, there itself they have said the advantages of TIVA over volatile agents could not be well established. So therefore, if somebody is very familiar with the TIVA, they can use it. Otherwise, you can go for volatile agents also. Next one. And with regard to the use of supraglottic devices, the use of supraglottic devices as on this date is slightly controversial, because ultimately what we want is a good sealing pressure. A good sealing pressure in the face of a varying position and the pneumoperitoneum. If that is attained, it can ensure a correct ventilation and reduce the potential risk of aspiration, especially when it allows a passing of a gastric tube through it. Next one. Although the incidence of regurgitation and aspiration during the use of LMA is very low, hardly any cases are reported, but still there is a limited evidence at this moment to suggest that they are completely safe against aspiration. So therefore it is, once again, you can use it if you think that the stomach is really empty and there is no head-low position and the chances of regurgitation are less. So in such situations, you can go for any of the supraglottic airway devices, especially the 2nd generation ones. Next one. And with regard to the use of balanced anesthesia, short-acting IV drugs like propofol and etomidate can be used there because they are quite safe, both in the elderly and the children. And analgesics like remifentanil or fentanyl, they produce a short duration of analgesia, and good relaxation is achieved with the use of atropurium or drugs like rocuronium, which are freely available nowadays. And as far as the volatile anesthetics are concerned, sevoflurane probably is the best one, or even isoflurane is equally good because the incidence of arrhythmias and other things are much less during this particular procedures. But the use of this dexmedetomidine as adjuvant during the laparoscopic procedures has really revolutionized and made the job much more easier and a simple one. Next one. Whatever be the technique you use, so whether you are using TIVA, you are using volatile anesthesia, you are using endotracheal tube or the supraglottic devices, what are the matters of a concern during the laparoscopic anesthesia is, first thing is, one is deep muscular relaxation is necessary in these patients. And what is the mode of ventilation that you use, whether you are using a volume controlled ventilation or a pressure controlled ventilation. what is the PEEP that you want to use, alveolar recruitment menus that are required, and the IE ratio, what is used in these cases. These are some of the matters that are discussed quite often. Next one. As far as the deep muscle relaxation is concerned, what is recommended is the post-tetanic count of below 3 or at of the 10 or 4 count of less than 1, that is, you can call it a 0 or 1, is one which provides a deep muscle relaxation. And because the good lateral lift and the operatic conditions at a low intra-abdominal pressure are possible with this deep muscle relaxation. And this muscle relaxation allows the ventilation to maintain the carbon dioxide, EtCO2, between 30 to 35 only, even during the prolonged procedures. That's what I was stressing upon, because we can't always rely on this. And what is one factor that is established is this deep muscle relaxation is known to reduce post-operative pain in bariatric laparoscopic procedures. This is a well-established fact. A good review was published by the Putzbuder and in Minerva Anesthesia, a very recent article what I could see. It's an excellent review was done, a neuromuscular block in laparoscopic surgeries. And this advantage, the advantage of this deep block till the end of the surgery, what I was referring to earlier, must be balanced against the risk of residual paralysis. Because once we reverse the patient should not go into a residual paralysis. And this particular factor, the effect of deep neuromuscular blockade on a surgical conditions and the patient outcome is new field of research. I think not many public articles are seen. Probably we can take up these things in the days to come as our research work. Next one. And what shall be the ventilation strategies? I have already told you during the pneumo, what are all the respiratory physiology or pathophysiology takes place. That is, peak and plateau airway pressures are increased by as much as 50%. The dynamic and static lung compliance, I showed you with that image, as much as about 50% the compliance will be reduced. And the basal lung collapse occurs after some time. The FRC is reduced. The hypoxemia because of the VQ mismatch is also seen. These things we have seen already, I have told you. Next one. So therefore, what is important is whether we can use, instead of a volume controlled ventilation, a pressure controlled ventilation can it be used. Because it is claimed that the pressure controlled ventilation provides a lower airway pressure and greater dynamic lung compliance than when compared to the volume control ventilation, especially in the deep head-low positions. This is what was the thing by Cardi and others in the 2008 publication. I could see this. And another thing what is noticed is better respiratory mechanics and oxygenation take place in obese patients. So definitely the pressure control ventilation is preferred in obese patients because it has got a lot of advantages. However, in other patients, what is its utilization when compared to the volume controlled is once again a matter of research. Next one. The one disadvantage I would like to tell about the pressure control ventilation is whenever the pressure is altered, say when the abdominal pressure increases or decreases, the sudden changes in the tidal volume, because during the pressure control ventilation, the pressure is maintained uniformly. So if the intra-abdominal pressure suddenly releases, the tidal volume may increase, and the reverse may happen when the intra-abdominal pressure increases. So therefore, that is one of the disadvantages we need to keep in mind. And to minimize the post-operative pulmonary complications, when we look at this complication, post-operative complication, a protective mechanical ventilation is necessary, and that can be achieved by using a low tidal volume of about 6 to 8 ml instead of earlier we used to use say 10 or 12 ml per kg body weight. Remember, ideal body weight is better. We use it for this purpose. And plateau pressure should be maintained as far as possible below 16, which may be very difficult in certain situations. It may go as high as 20 to 25 centimeters also. And moderate PEEP is beneficial except in obese patients. Obese patients, the PEEP has got a different role by itself. Of course, one of the narrative reviews published in 2007 talks a lot about this ventilation strategies, and these are found to definitely benefit the patients as far as post-operative pulmonary complications are taken into consideration. Okay, can we use PEEP? What is the role of a PEEP in this particular case? During the pneumoperitoneum, as I said earlier, the increased intra-abdominal pressure combined with the PEEP further may decrease the venous return. This is what we theoretically believe. And by increasing the ventricular afterload, it can also reduce the cardiac output. This is what we think about the theoretically. But some of the published reports say differently, especially during the robotic prostatectomy, where the very, very steep headlock position is given. There it was observed that application of PEEP was found to significantly improve the oxygenation. This is one important observation that is made. So therefore, what it was recommended is in obese patients or in patients where such steep headlock positions are given, a PEEP of about even 7 to 10 centimeters may be necessary. That may be rather helpful in this particular patient. Next one. And another important thing is alveolar recruitment maneuver. Just to tell you what the alveolar recruitment maneuver is, alveolar recruitment maneuver opens the collapsed alveoli, and further on after that, if okay, my sound is lost, Bhaskar.
No, we can hear.
Okay. Alveolar recruitment maneuver actually opens the collapsed alveoli, and once that is done, if application of PEEP, it prevents the alveolar de-recruitment or alveolar collapse is further prevented, especially during low tidal volume ventilation, what I recommended earlier. So therefore, a combination of this alveolar recruitment maneuver combined with PEEP even up to sometimes 10 to 15 centimeters is very beneficial, especially in obese patients, not a bariatric procedures. How it is given, the alveolar recruitment maneuver, the pressure is increased up to 40 centimeters, and we can maintain that particular pressure for some time. And about 8 to 10 such sustained lung inflations, if we provide, a good alveolar recruitment is possible. And later on, we can apply the PEEP over those things, and we can continue so that the patient is benefited and the hypoxemia is kept under minimum. But thing is, theoretically, again, I repeat, this is likely to compromise the circulation. We need to be cautious about hemodynamic monitoring. It is very, very essential. We need to be cautious about that. Next one. And what is the IE ratio that is good for this? We all know prolonged IE ratio or increasing or reducing the expiration has a possible benefit. I mean, the prolonged one has got a possible benefit of improving the oxygen delivery by preventing alveolar collapse. But theoretically, what happens? Prolonged inspiration may result in carbon dioxide retention because there is not much of a time is given for elimination of the carbon dioxide. So therefore, it is an issue of a controversy. But however, what I was reading was during the pneumoperitoneum, an IE ratio of either 1:1 or even 2:1. Say the inspiratory time is double that of the expiratory time. It may improve the respiratory mechanics, the arterial oxygenation, and without affecting the cardiac elimination. And this is possible by decreasing the dead space and increasing the alveolar ventilation, especially in this laparoscopic bariatric procedure. I'm referring to all these things in a bariatric procedures or obese patients. So therefore, this also is a matter of discussion, and we need to really see how they are beneficial, 1:1 or 2:1 IE ratio in these obese patients. So that is about the general anesthesia. And the other option I told you earlier is regional anesthesia. Whether regional anesthesia can it be used? Yes, there are a good number of consultants who prefer this regional anesthesia, but then there are certain limitations. Very high block is required. Sometimes up to 4 it is required for a comfortable pneumoperitoneum, so that the patient does not complain of the stretching of the diaphragm. And this automatically comes with higher incidence of hypotension. And also, because the height of the block is pretty high, there is a likelihood of hypoxia because of the intercostal paralysis. In addition to that, some of the anesthetic or analgesic drugs, if we have administered, especially the pre-medications, the respirator may be further affected. And also, these pre-medication drugs may increase the carbon dioxide sensitivity, so the patient may not respond with the hyperventilation in response to the carbon dioxide, elevated carbon dioxide levels. And so that is some of the disadvantages. And definitely it is an uncomfortable position if the head-low position is required for the surgical purpose. So therefore, it has got a role to play, especially in a few procedures, but not in all, because there are some of the disadvantages. So therefore, yeah, next one. So therefore, there are any of the anesthetic techniques can be used. You can use general anesthesia with either TIVA or inhalational procedures or regional anesthesia. See, all the things are open depending on your expertise, your experience, and the surgical condition and the patient's condition. And during the laparoscopic procedure, we need to be cautious about the intraoperative complications. Some of the very significant intraoperative complications. And one of the most important things that we need to remember is gas embolism or carbon dioxide embolism. And the incidence is very, very low. It is 0.6. Say, I can say, so till now, I have not seen an established case of a carbon dioxide gas embolism, despite my experience for the last about 20 years with the laparoscopies alone. What often happens is a delayed recovery or neurological problems are mistaken as embolism, but the incidence is low. And how it occurs, it is often due to direct placement of the trocar or the needle into a vessel, that is either the iliac vein or IVC in a very thin patients, or in obese patients, it can go into the periumbilical veins or venous plexus. In such situation, the gas may enter into the systemic circulation and causing the gas embolism. And but one thing is important: vascular injury after a pneumo is created, when the intra-abdominal pressure is elevated, they say beyond 10 centimeters of water, or after that, the complications of this embolism is much less because the gas cannot enter into the veins. I told you earlier that there will be compression of all the peritoneal vessels and the other veins. So therefore, the chances of embolism are much less. Next one. So what we need to do probably is start the pneumoperitoneum very slowly, initially at the rate of less than about 1 liter per minute. And I told you earlier, the carbon dioxide better. And the severity of this gas embolism depends on the rate of entry and the size of the bubbles. I'll tell you in the next slide. And a large amount of gas can form a kind of an airlock, what we see in our taps and other things. Such kind of airlock is created in the inferior vena cava or the right atrium, and causing the outflow tract obstruction and reduction in the venous return to the heart. So this is the mechanism. And patent foramen ovale, which is seen in almost about 20 to 30% of the population, they get opened up because of acute right ventricular hypertension. So possibility of a paradoxical embolism and causing the embolism of the cerebral and coronary vessels also may be seen if the unfortunate incidence of a gas embolism occurs. And yeah, another one is VQ mismatch occurs because once the gas enters into the lung, it may not be, the circulation may not be there, and therefore VQ mismatch goes up significantly and the physiological dead space increases with the resultant hypoxemia. So let us have one more question with regard to the gas embolism itself, what we are speaking. The manifestations of the gas embolism may include all except it is tachycardia, hypotension, mill-wheel murmur, or left ventricular strain pattern on ECG. Which of them is not correct following gas embolism? D, C, D, D, okay, D. Okay, left ventricular strain pattern. Okay, I think almost everybody agrees the correct answer. Next one. It is the left ventricular strain pattern. It is a right ventricular strain pattern is seen in these patients. The clinical picture of the gas embolism, I told you earlier, the size and the rate. When it exceeds more than 2 ml per kg rapidly, it is a possibility. The clinical picture may be seen, and it manifests as tachycardia or arrhythmias. Hypotension will be there, Millwheel-Wermer and cyanosis may be there. And ECG shows right ventricular strain pattern. Next one. And but all these manifestations may not be consistent. Please note, because the pulse oximetry may help in detecting the hypoxia also, but none of these things are consistent, and we need to be cautious about that. But then the capnography is most useful. It helps in early diagnosis, that is biphasic effect. I was telling you earlier, initial slight increase in the carbon dioxide followed by no carbon dioxide, that I told you, airlock. So there may not be any carbon dioxide. And if we are using a precordial stethoscope or esophageal stethoscope, it may help us in picking up a Millwheel murmur quite early, before even the clinical manifestations appear. So it may be useful. But then whether can we use it routinely, the esophageal stethoscope? The answer is no, because the incidence of gas embolism itself is very, very low. Next one. And if we are using a Swan-Ganz catheter or pulmonary artery catheter, that also can help. But once again, I told you earlier, it is dangerous monitor, may not be very useful one. But if it is there, catheter or PA catheter will help us in aspirating the gas and treat the condition. Next one. Okay, so one more question about the gas embolism. The treatment of gas embolism includes all. I think it should be quite simple. Stop carbon dioxide insufflation, release of pneumoperitoneum, steep head low position, and right lateral tilt. Okay. Except, the question is except C, 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 D. Okay. Any more answers are coming? C, D, D. Okay. The right answer is, it is not the, next slide please. It is not the right lateral, it is the left lateral tilt is required. We need to stop the carbon dioxide insufflation, release the pneumoperitoneum. Durant position is required, that is steep head low with the left lateral tilt. The purpose is the buoyant foam that is formed is pushed laterally and caudally away from entering into the right ventricle. That is the purpose. And if we are using nitrous oxide, we need to stop it. Or if you are using air, so there is no problem. We just continue with the oxygen alone. And if the CVP catheter, I told you earlier, if it is in place, aspirate the gas through the catheter. Next one. So another question, I think I will have a few more questions now before I conclude. Some of the questions, interesting questions for the postgraduates. Embryonic potential channels are known to exist, you know it. And opening of the pleuroperitoneal duct due to carbon dioxide pneumoperitoneum causes mainly right-sided pneumothorax or the left-sided pneumothorax. Only two choices are there. It is easy to answer. Okay, A. Okay, A. All right, I think, okay, there is one person who says B also, but majority are telling A. The next slide, please. The gas leak through the potential channels, that is embryonic remnants of a potential communication between peritoneum and the pleura or the pericardial sacs is a normal phenomena. And when the intraoperative pressure increases, they may open and it causes right-sided pneumothorax. Okay, so it causes right-sided pneumothorax. When does the left-sided pneumothorax occur? It occurs when there is a pleural injury, especially during fundoplication procedures. In such situations, left-sided pneumothorax. So you can make out, depending on the type of the pneumothorax, which side of the pneumothorax, what possibly caused this. If there is a pneumomediastinum, the desaturation will be there, and paradoxical or uneven movement of the diaphragm can be visualized during the laparoscope itself. Next one. And treatment is simple. 100% oxygen, stop nitrous oxide if you are using it. Allow PEEP. No PEEP if the pneumo is due to ruptured bullae. Remember, if it is only pneumomediastinum through the remnants of the embryonic remnants, then allow PEEP and decrease the intra-abdominal pressure. And if there is a pneumothorax, it may resolve after some time, the pneumomediastinum. And another complication that can occur is the subcutaneous emphysema. I told you earlier, it is an unavoidable accompaniment during renal surgeries or during the hernia repair or a fundoplication when the peritoneum is incised and to place the mesh or something like that. And here the carbon dioxide under pressure may reach the mediastinum, and even it can go up to neck and the face. In many cases, we see this phenomena. And in these cases, the EtCO2 increases after the initial plateauing. Say normally about 15 minutes or so, it gets plateaued, but in these cases, it may continue to rise, they say EtCO2. So that should suggest the possibility of a subcutaneous emphysema. Next one. So the carbon dioxide pressure is the one which determines the emphysema and the magnitude of carbon dioxide absorption. So therefore, we need to, all that is required is stop the procedure temporarily and proceed with a low intra-abdominal pressure. And remember, the subcutaneous emphysema is fairly safe. It readily resolves after stopping the carbon dioxide pneumo. And it is better, I feel, it is better you keep the patients on ventilator even in the post-operative period, because even otherwise also the carbon dioxide gets eliminated, but then it comes with the cost of increased work of breathing. So to keep that to minimum, it is better to ventilate the patient in the post-operative period for some time until the emphysema subsides. Next one. It's a simple question. Arrhythmia during laparoscopy do not correlate with the increased PaCO2. True or false? Arrhythmias do occur. It is true or false? B. Okay, B. All right. Many people are going with the answer B. Next one. Yeah. Your answer is right. The arrhythmias do not correlate with the increased PaCO2. It can even be because of the increased vagal tone, because of the sudden stretching of the peritoneum and the light anesthesia. I told you earlier, especially during the lighter planes of anesthesia. But then carbon dioxide gas embolism can manifest as arrhythmias. And in such situation, probably stopping the insufflation and deepening the plane of anesthesia is sufficient. And if there is a bradycardia, probably we may require atropine or glycopyrrolated such drugs. Next one. Okay, these are some series of situations I am giving. Please get ready to answer. Okay, the situation, clinical situation number 1 here. The capnography shows normal. Pulse oximetry shows desaturation, hypoxia. Airway pressure is increased. The air entry and auscultation is reduced. On the percussion, there is a hyperresonance of the chest, and there is no hyperresonance, and there is no crepitus. What is the possible diagnosis? Your quick answers: endobronchial, bronchospasm. Okay, any more answers? Endobronchial pneumothorax, endobronchial pulmonary edema. Right. Okay, next one. The answer is endobronchial because there is no hyperresonance, there is no crepitus. It has gone into one side, so therefore reduced air entry on one side will be there, but the airway pressure will be increased and possibly the pulse oximetry shows desaturation. Next scenario, please look at it. Be ready with the answers. The EtCO2 shows elevated carbon dioxide, but the oximetry is normal. Saturation is normal, airway pressure is normal. There is no reduction in the air entry. Air entry is normal. Hyperresonance is not there, but then crepitus is present. Subcutaneous emphysema answer, emphysema, surgical emphysema, okay, emphysema, subcutaneous emphysema, okay, right. Next one, next slide, please. It is subcutaneous emphysema is the correct answer because there is a crepitus and the carbon dioxide is elevated. Rest of it is all normal. Okay, get ready with the next one. Carbon dioxide is elevated. SpO2 is low, airway pressure is elevated, right? Then air entry is reduced, hyperresonance and palpation, percussion, and crepitus may or may not be present. Please note there is carbon dioxide is elevated and there is hypoxia. Pneumothorax, pneumothorax, pneumothorax. Okay, pneumothorax, pneumothorax, pneumothorax. Okay, next one, next slide please. Mediastinal emphysema. It is capnothorax. Please note there is carbon dioxide is elevated in this case. That's why I was stressing upon it is carbon dioxide is elevated. Rest of the things are all going with the pneumothorax. Next one. Okay, this scenario, the carbon dioxide is down, it is low. The saturation is also low, but the airway pressure is elevated. Air entry is reduced, chest is hyperresonant, crepitus may or may not be present. Yes, your answer please. Different from the previous one is the carbon dioxide instead of elevated, it is reduced. Otherwise, it is the same one. Bronchospasm, bronchospasm. Okay, any more answers? Bronchospasm. Next one. Next slide, please. It is a simple pneumothorax. That is the reason why the carbon dioxide is low. Okay, the next one. Carbon dioxide once again is reduced. This desaturation is there. The airway pressure is normal. There are murmur. Will murmur. It's very easy to answer. I don't expect any wrong answers in this. The blood pressure is reduced and the ECG shows some changes. Okay, I think almost all answers are correct. Right. Okay, next slide. That is carbon dioxide embolism. Remember, embolism is there. So this is how the monitoring will help us in detecting what particular type of problems are there in these cases. Okay, this I have picked up from our Miller textbook. I think you can refer it once again to the same one. Next slide, please. So there is something special about the post-operative management. A little I'll consider in the next few slides. Next one. Post-operative analgesia is a very, very important phenomenon in this. And with this, in this regard, the Prospect collaboration, which is a committee of pain management experts, they have done an excellent review work, more than 258 articles and published in 2018. They recommend multimodal pain relief. That is the best one, like paracetamol or NSAIDs and opioids can be used. Even regional analgesia or surgical site infiltration with the local anesthesia preferred ones. But however, they have found that gabapentinoids, what are used, or intraperitoneal local anesthetic infiltration and tap block may not be beneficial. They are very categoric in this after doing the systematic review, and they say that this may not be a very useful one. However, I was going across the review literature wherein even erector spine block is tried at the level of T10. Some of the studies, but I do not know its authenticity, how far it's beneficial. But we can do some kind of a research in this particular thing and some study can be done. Next one. PONV, I told you it's a very severe one when compared to laparotomy incidence is very high. So when you are using propofol, it may be beneficial. And other drugs like ondansetron and metoclopramide or scopolamine patch may be beneficial. Next one. Next slide. And one or two slides about the morbidly obese. I have already covered some of them. One thing that is important here is thick abdominal wall and the increased intra-abdominal pressure. That is there in these patients, morbidly obese patients. So therefore, as such, they have increased work of breathing and reduced pulmonary compliance. And the closing volume forms large part of the FRC. So these things we need to obviate whenever we are doing conducting anesthesia. Next one. So we need to resort to mechanical ventilation, which helps us in reducing the work of breathing and oxygen requirements are reduced. The CV to FRC ratio is improved and the oxygenation helps. And there is decreased tendency of a pulmonary congestion. And workload on the cardio also is simultaneously reduced, especially in these obese patients. Next one. And Varis needle is very, very advantageous in these patients. And intra-abdominal pressure just around 14 to 16 is quite sufficient, quite a good compromise between the adequate ventilation and the venous return. And here, once again, good muscle relaxation is very beneficial. And these patients, today's patients, they do tolerate a head-up position better. And what we need to remember is the pressure joints must be padded to prevent nerve injuries in these patients, in morbidly obese patients. So these are some of the benefits of these laparoscopic surgery and the anesthesia. To summarize my talk, minimally invasive surgery have tremendous benefits, minimal stress response, and the post-operative pain when compared to the laparotomy. Patients here will have a distinctly rapid recovery and the short hospital stay, which is really advantageous. And increased intra-abdominal pressure and use of carbon dioxide can cause a few problems. Even in high-risk cardiac patients, they can be managed quite effectively. Next one. But what is important is, next one, a sound knowledge of a pathophysiology will allow us to conduct a safe anesthesia. Even in high-risk cardiac patients these days, you can conduct it. And there is a great potential for research because not many articles are seen with regard to the usage of supraclotic airway devices or deep muscle relaxation, what I told, and the ventilation strategies, except for the PCV usage. Not many articles are there. So there is a scope for a lot of studies in this area. So thank you very much. And these are some of the references what I had used in addition to what I already cited there. Thank you very much. So thank you once again for giving me this opportunity to speak. I'm ready to take any questions that are there in the chat box or anybody can discuss. I can see some of my senior colleagues. Anybody would like to share their views and experiences in this?
Thank you. It was excellent, despite some technical hiccups in between. It was too good to be true, and I hope our PGs especially have taken home a lot of message. And I will try to get into the chat box. And meanwhile, as Sir is suggesting, I would request inputs from our senior colleagues who are participating in today's program.
Venkatagiri is there. You can begin.
Sir, I will, because of the disconnection in between, I had saved the chat messages also. But one thing is, I will try to come in the reverse direction with respect to summary questions that are put in the chat box. So there is one question related to the role of nitroglycerin on the role of during the laparoscopy. I think this is in the background that we encounter hypertension during the laparoscopic procedure. And one of the ways that is tackled in practice is by using nitroglycerin as an infusion. So you have your opinion on this, sir?
Yeah, nitroglycerin only symptomatically it can bring down the blood pressure, but the fact remains is it is the peritoneal stretching under lighter planes of anesthesia is the one which is responsible. So there is nothing like deepening the plane of anesthesia and use of adjuvants that is more important than simply using the nitroglycerin, because it can create a lot of biochemical changes in the body.
Yeah. So the secret of management is ultimately the balanced anesthesia for the particular case, I think. So if at all, if the borders of balanced anesthesia, we have done everything perfectly, and despite that, the patient has gone into some persistent hypertension, we should be trying to rule out all the causes which are precipitating the hypertension. And then I think as Sir was discussing, dexmedetomidine has been one drug which has been giving excellent results. So it's going to reduce anesthetic requirement. It's going to produce some sympatholysis. That's going to produce excellent analgesia. It's going to produce very good heart rate profile, and even the blood pressure will be well maintained. So a judicious use and cautious use of dexmedetomidine would help in reducing the blood pressure. And of course, if there is indeed a need for an antihypertensive, despite all this, I think we can then definitely think of the other vasodilators before we think about nitroglycerin, because nitroglycerin can still produce increase in heart rate and
It is
with other adverse effects. We can still go for beta blockers or labetalol, which can be a useful adjunct there. So then I can pick one more question. How about using pressure control, volume guarantee ventilation to avoid hypercarbia as pressure increases in the airways?
Yeah,
So
I told you the only disadvantage of pressure control ventilation, of course, there are encouraging reports. The only thing is when the pressure changes, intra-abdominal pressure changes, the volume can fluctuate, the tidal volume can fluctuate significantly. That may have some kind of a deleterious effect. So that is the only disadvantage. Otherwise, the PCV probably is a good one, but not being used in many institutions, including our own institution, we don't use it. It should be a good tool.
Okay. Related to regional anesthesia, I did expect questions like this. What about segmental spinal anesthesia for lap cholecystectomy?
Segmental or anything, whatever be the thing, ultimately our aim is we have to, entire abdomen needs to be distended. And the nerve supply stretches, I told you, from T4 down to the S4, S5. So therefore, segmental epidural per se, I doubt very much. Yes, it is spinal anesthesia and epidural anesthesia are being given for that. But segmental, I neither have an experience nor any favorable opinion from my side. Anybody can, who is trying that, or the person who has asked the question, they can unmute.
Yeah, before they come in, I think there are anecdotal case reports which have been published. Generally, Italian studies where they talk about segmental spinal anesthesia. Of course, I concur with Dr. Sharsoor here that they are more like anecdotal reports only. They will stay like that only because it's very difficult to justify these approaches when we talk about the universal application of that particular technique. And of course, definitely there is a risk of not being able to restrict the level of block, and there is a risk of involvement of the cardio-acceleratory fibers. And in the extreme event of even a subclinical embolism, the normal compensation produced by the cardiovascular system may be lost, and that can prove fatal also. So that's one of the limitations. Of course, there have been reports, and even some of the practitioners suggest that they have tried this and it is working, and they are very happy. Can there be input from any of our seniors here?
Myself, may I talk, sir?
Yes,
Yes,
sir.
sir.
Please, sir. Welcome, sir.
Sir. First thing, congratulations, Dr. Sharsoor, for your good talk.
Thank you, sir. Thank you.
And one thing I want to tell, this is for the postgraduates, not for the academic discussions. The postgraduate must clear their mind about the subject and giving anesthesia and laparoscopic surgery. Agreed?
Yes, sir.
And with your talk, no external can dare to put the negative result against him if he is sincere with your lecture. Thank you.
Yes, sir. Yes, sir. So generally, when as you suggested, this is thank you, sir. This is basically PG-oriented topic, and of course, question has come from one of, I think, our senior colleagues and practitioners.
I appreciate this thing. I appreciate that thing, their thoughts. But
yes, sir.
If they have listened Dr. Sharsoor's lecture carefully,
Yes.
Nobody can dare. That is my conclusion
Thank
of
you,
the
sir.
lecture.
Good.
you, sir.
So
Thank
I
you.
think we should be not promoting PG teaching. So we should stick to the standard teaching and standard management of the patient. And of course, there are reports of such cases being performed under segmental spinal also. And there is one question. Cause of VT during laparoscopy. I think ventricular tachycardia is the one that is implied. Sir?
What is that a question?
No. That is a question. cause of VT during laparoscopy?
Particular tachycardia, that may be because of the elevated carbon dioxide. I told you that is the only cause that is possible, especially during the prolonged procedures when we will not be really able to detect what is the PaCO2 unless we do it. EtCO2 may not reflect the true PaCO2. In such situations, we may see some kind of a tachycardia.
Yeah, it is very unusual to have. It could
Unusual
be,
to have, but
could be supraventricular tachycardia.
Supraventricular,
It will be related to VT. I request participants, the viewers, to please mute themselves, their own phone.
if they are not asking question.
Sir, what about combination of epidural analgesia and general anesthesia? There are literatures related to use of combined epidural and general anesthesia for laparoscopic procedures.
Yeah, I told you the prospect collaboration very strongly recommends the pain following post-operative, pain during the post-operative period in laparoscopic procedure is the same as that of a laparotomy except the dynamic pain. So therefore, a combination of a epidural with the general anesthesia is an excellent one. And it is approved by the prospect group.
Yes, sir. So despite our understanding that it's a relatively painless procedure, we need not talk about epidural and all. So it has been found to be definitely beneficial when we add on epidural analgesia and intraoperative. We are going to provide the best analgesia for the patients. Sir, there is a very, let me mute everybody once again. You may please unmute yourself, sir. Yes, I muted everybody, and sir, you can unmute yourself, and anybody who wants to raise a question, they can also unmute. So there is a nice technical academic point raised by Dr. Swati. She has talked about endotracheal cuff pressure increases by virtue of pneumoperitoneum, as well as positional changes might be of significance in prolonged lap surgeries. Yes,
it is a well-established fact. It is a well-established fact that prolonged laparoscopic procedure with the carbon dioxide pneumo is known to increase the cuff pressure, and also the upward movement is there. So I think even very recently an article was published in our Indian Journal of Anesthesia itself about this, and a good study they have conducted. So therefore we need to be very careful during the prolonged procedures. Swati, yeah, from BMC probably.
Yes. And there has been a suggestion by Dr. Vasanta from Mangalore. Yes, dexmedetomidine is very good. And one more of our viewers has suggested that clonidine is equally good.
Yeah, clonidine is good, or I can say it was good. And ever since the dexmedetomidine is introduced, the role of clonidine is slightly fading, because definitely dexmed has got a far superior qualities when compared to the clonidine, because both of them belong to the same group of drugs. Yeah. So that's one advantage is that clonidine is a good drug, but definitely its residual effects would be there for a longer time, and it is difficult for us to titrate the dose of with respect to the alpha agonism with respect to clonidine as compared to dexmedetomidine. And of course, as we discussed about the labetalol, there has been a question: role of labetalol for control of hypertension. We discussed about NTG, sir. Now same thing.
Ask about role of labetalol. I think we can. It's a better drug.
Definitely.
We can give intermittent boluses.
Both the alpha and the beta blocking properties, so therefore it will be much superior when compared to the other drugs like nitroglycerin.
Yeah. So Dr. Utpal Datta has raised a surgical point in the sense in one of the surgeons never uses Verey's needle. He does very rapid insufflation. How dangerous it is?
Yeah, it is not uncommon to use directly the insufflation without using the Verey. Some of the experienced people do use it, but the rapid inflation is not the one. Rapid inflation is initially more than 2.5 to 3 liters per minute. That will cause the problem. And another thing, in the lighter planes of anesthesia, the problems are more often seen. If it is a deeper planes of anesthesia and a very good relaxation, I always insist my students, even before and now also, that go for an excellent relaxation right from the beginning till the end. So when the relaxation is good, this rapid insufflation may not be very dangerous, but if it is possible, better we avoid it.
Yes, sir. So at least hypothetically speaking, if indeed the needle has just at the point of entry up into a vessel or something,
Then
rapid insufflation,
yes,
there is a greater risk definitely those patients. And of course, NTG versus labetalol, Dr. Venkatagiri, our current national intellect, has commented. Yes, NTG also always has got the advantage of titration when you start as use as an infusion. Yes, in practice, as I told you, it is a very good drug. A seasoned anesthesiologist will be able to control the blood pressure very nicely with NTG. So only as a take home for the postgraduates, we suggest that labetalol will be a better drug as compared to NTG. And even when we talk about segmental spinal, Dr. Vasanta has again commented, definitely comfort of the patients. There are many other discussion points which come into play, which Dr. Sharsoor has already covered. So patient developing intercostal muscle paralysis, definitely you will see that patient becomes extremely restless, even though the tidal volume would appear to be well maintained. So these are some of the practical things. So they are not advisable to be suggested as techniques of anesthesia for laparoscopies. Why in air embolism? There is a question. Why in air embolism head down position? Sir.
Head down position alone is not recommended. It is actually the left lateral position that is more important, because what we are interested is the foam that is formed by the gas that should not enter into the right ventricle. That is the purpose. It is not the head down alone. So that is.
Sir, again, you can unmute. If you are muted, please unmute again.
It is not the head down position alone. It is the left lateral position that is more important, so that there is no right ventricular outflow tract obstruction. The air should not be allowed to enter into the right ventricle. That is the purpose. So it is not the head down position alone that is beneficial in these cases.
The benefit of head down is that the air being lighter, it becomes most non-dependent.
Yeah.
So that is the one which is
expected. Yeah.
There is an unrelated question. I will not take it now. So remifentanil, yes, remifentanil would be the best drug if it is available. Unfortunately, it is yet to reach India in terms of manufacture and marketing. Your experience with shoulder pain after lap surgeries?
Yeah, we have seen the patients with shoulder pain earlier. That is when we were using the air. But the present day practice, after we started using the carbon dioxide, the incidence of shoulder pain surgeries is much less, because even we used to use about very dilute concentrations of local anesthetic injected into the under the surface of the liver to minimize the shoulder tip pain. That was only when air was used. That is quite less. We hardly see any such cases right now.
How much maximum EtCO2 can we accept during extraperitoneal lap surgery?
It is not the quantum, but it is the duration that is there, because ultimately what is required is we need to ventilate the patient to adjust the EtCO2 in that. Of course, a permissive hypercapnia, almost say 50-55, will not really cause any arrhythmias or such things. But then we need to make efforts to keep it under control. That is by ventilation. Almost even 50, sometimes 55 also, we have seen the carbon dioxide going up. Especially during the renal procedures, nephrectomies and such procedures, the carbon dioxide levels do go up very high.
What should be the safe left ventricular ejection fraction in cardiac patients? Apparently, I think for laparoscopy.
I don't think anything can be called as a safe. It all depends. It's a multifactorial one. What is the type of the procedure? What is the duration of the procedure? And the laboratory cannot be. I personally do not have an answer for this. It is a multifactorial. If the person iPhone, the question, if they have got anything, they can express it.
So definitely, as you say, we talk about proper choice of the patient in the preoperative assessment.
Yeah.
For a particular procedure with a particular surgeon also, many times, and with the comorbidities which are part of that particular condition.
Yes.
And if indeed we talk about a patient with moderate reduction in left ventricular ejection, so we are definitely happy if it is beyond 45.
45 is the minimum.
We are generally happy.
Yes.
We can, for example, for the benefit of the PGs, we can say that anything above 45, we'll be very happy to take up the patient for surgery. We will not be worrying too much about the deleterious effects. The second part is when we talk about something between 25 to 45, it's a moderate risk. And if your setup is good enough to see that any decompensation that might be precipitated in the intraoperative period, you can always take it up. There is never a problem. And beyond that, a very low EF. So that's a decision which should be taken in consideration with the cardiac anesthesiologist, cardiologist, and everything, because ultimately the patient's safety is more important for us. So those should be the determining factors rather than us deciding per se individually. Any special precautions in pregnant and pediatric lab procedures?
Yeah, pregnancy, of course, I did not deliberately cover it, but any procedure that is done during the second trimester of pregnancy is pretty safe, that number one. And yeah, left lateral tilt is a necessity. That is, I mean, right lateral tilt is a necessity. That is the thing. We cannot afford to forget it. And the good thing about the laparoscopy in pregnant mothers is, though the carbon dioxide levels in both the mother and the fetus do increase, they hardly produce any significant deleterious effects. And the carbon dioxide, once the carbon dioxide level comes, even the cardiac rate will come down to normal. Only thing is, we must limit the pressure, insufflation pressure, to about 15 millimeters of mercury. And using the Very's needle may be a little tricky, because if the uterus is distended, then we don't know. They were suggesting gasless lap, but it is not done these days. And some of these surgeons, they do even think of using the tocolytics. So that, but that is a controversial one. Whether it is got really benefit or not is a controversial issue. These are some of the things about the.
There will be technical things which are related to the obstetrician handling the procedure. Of course, enlarged uterus, then the position, and some consideration related to supine hypotension, and maintaining the volume. So these are the routine considerations which you should be careful about.
And another thing, the ETCO to PaCO2 to ETCO2 difference, what we normally say about less than 5 to 6, that may not be applicable in these pregnant mothers. It can be much higher, about 10, sometimes 15 millimeters of mercury. That is what is described. And it is quite compatible, and it does return to the normalcy. That is the one thing, it is written in the textbooks actually.
But if we talk about pregnancy for coming for laparoscopy, normally it's like an acute status. So patient coming with ovarian cyst, twisted acute ovarian cyst, and we have got acute appendicitis. And of course, very unusually, cholecystitis has also been discussed in pregnant patients. And our general considerations have been trying to have them in a elective procedure to be done, if at all required, in the first trimester. Otherwise, if the patients do come in emergency procedure, we are left to tackle these patients, and we have to only, I think, judiciously and use the drugs, especially the first trimester if there is some problem. And otherwise, it has to go into the third trimester or post-pregnancy, post-delivery. I think this is more important from our side. But first trimester, an emergency patient coming with an acute twisted ovarian cyst emergency, it's very difficult for us. Only thing is, I think from my point of view, surgeon should be very good. Minimal exposure to the anesthetic agents and drugs in the first trimester when it is required. That call must be taken as a teamwork, basically. Sir?
Yeah, that's actually whatever because of this, I told you, no, the EtCO2 and PaCO2 difference. PaCO2 will be much elevated, and maternal and fetal acidosis, they are not known to produce a long-term effects. The moment you stop insufflation, they come back to the normal. Hardly any problems are seen. That is one good thing about the thing.
Anything about pediatric lab, sir?
Yeah, pediatric laparoscopy ventilation is independent. I told you the pressure control ventilation is a necessity. And the second thing is the intra-abdominal pressure should be kept not more than about 6 to 8 or less than 6, you can say, in infants and neonates, and in grown-up children beyond, say, about 8 to 10 years, it can go up to 10 to 12 years. And that is directly proportional. The EtCO2 will be directly proportional to the intra-abdominal pressure. More intra-abdominal pressure, more of this one, the EtCO2. Because the reason is the intra-abdominal wall is very large compared to the body weight. Peritoneal surface is very large. Some disturbance. That is the one thing we should keep in.
Okay, sir. And meanwhile, very important, a point supplemented by Dr. Vasanta, that in pregnancy, we should always be trying to monitor the fetal status. That's very important, of course.
Yeah.
Through. Then I'm getting into the chat box here. Again, somebody has asked, can we advocate regional anesthesia like central neuraxial blocks that we already discussed? Then how about using pressure control? That is done. Okay. There are a lot of chat entries with respect to the questions that you have put. So the PGs have been very active.
Yeah, many have answered the question. Any expert opinions?
Yes, I will try to see. Dr. Chakrarao is there. Sir, good evening, sir. Welcome.
Good evening, sir.
I'm just two editors conducting. So I must see and.
No, but your suggestions are very, very well taken, sir. You please, we need your experience, your expertise.
No, it's like no question about resuscitation.
Yes.
During laparoscopy.
See, unless, there will not be any problem for resuscitation unless there is a big gravity uterus and falling on the inferior vena cava. There will not be much.
Yeah.
And of course, we have to keep it in the left lateral position and do the
Placement is a necessity.
And
yes.
Otherwise, the pressures, as you said, let them not increase more than 12. And that 12, 14 they will say, but we have to restrict them to 12. And of course, children, as you said, it is there. And the carbon dioxide, whatever that is absorbed, it will be washed out very easily within few minutes. There will not be any problem of any acidosis or anything with this carbon dioxide. Of course, EtCO2 monitor, of course, many people are doing laparoscopies. I should blame the anesthetist. Without a EtCO2 monitor, which should be condemned.
It's not fair, sir. It's not fair in the present era to do a case laparoscopy without a EtCO2 monitor.
EtCO2 monitor.
So one more thing I would want to convey to postgraduates when we talk about regional anesthesia, central neuraxial blocks. So one important problem theoretically is when you are given spinal anesthesia, apparently if you have decided to give spinal anesthesia for a laparoscopic procedure, or you are given epidural also, there is going to be sympathetic block in the lower extremities. So sympathetic block would persist as long as the drug is attached to the neural tissue. And normally we know if it is, even if it is bupivacaine, it will last beyond analgesia also. It will be there for next minimum 3 hours, 2 to 3 hours. So imagining, even though it is unusual, an air embolism or a catastrophic air embolism, when we try to resuscitate the patient, it is very, very difficult to resuscitate the patient in the background of sympathectomy in the lower extremities of the body.
Yes.
So this is one we have to keep in mind. So we never should be advising a central neuraxial block, number one, and even a segmental neuraxial block. Of course, that choice is left to a senior consultant.
Shoulder pain is another thing which we cannot stop in the neuraxial block. Shoulder pain will be there because of the diaphragm stenting and all those things.
Yeah, all those things are there, sir. And because some of our, there have been some publications. That's the reason some of our colleagues have also been doing it in private practice. So one important word of caution is that sympathectomy. Imagine the patient going into air embolism and there is no blood pressure, a massive air embolism, obstructing a big pulmonary trunk or a big branch. And when you try to give vasopressors, they are not going to act on the affected segments. And the response also is not as we, for example, we do talk about giving mefentermine and all during intraoperative period, but it works in the unaffected parts of the body, in the upper half of the body, and tries to maintain the blood pressure. So this is not going to happen. So this is definitely a no when we talk about laparoscopy. No regional central neuraxial block. This I wanted to convey.
Vishwanath Hiremat is there?
I am just seeing.
Vishwanath Hiremat, Pondicherry. Okay, anybody else?
Dr. Vasanta was contributing a lot to the discussion in the chat box. Dr. Vasanta, you are there, madam.
You can unmute and speak.
Dr. Vasanta.
Venkatgiri also.
Yeah, I am here, sir.
Yeah, madam, thanks for good supplementary inputs in between.
We did that Dexment and all in studies.
Yeah,
Dexment and Dexment is actually very good.
Yeah.
And preemptive paracetamol with Xylocard we give.
Okay.
That also is very good.
So it's a part of multimodal anesthesia.
Yeah. Then port infiltration also we give.
Yeah, port infiltration is another recommended one, which has got excellent
that also
results.
we give.
Yeah.
But some people will have shoulder pain, sir.
Yeah,
Yeah, it is there.
Then some studies are there, interscalene block and all. I don't know whether they are anybody giving.
No, those are there. Yes, madam, agreed. That's why our aim is to say that yes, we have to produce multimodal analgesia.
Yeah.
Of course, it does start with the port site infiltration, either at the beginning or at the ending. There is also some.
Some people are giving instillation, intraperitoneal instillation of block.
It's also good. It also works out nicely, especially.
This Rajesh is giving, I think, baby memorial. They told.
Yeah, it works. It works nicely. And,
but whether the surgeon will allow, I don't know. That actually I wanted to give. Surgeons, this thing, acceptance, I don't know. Intraperitoneal means sometimes they don't allow, I think.
No, it's actually a simple technique, madam. You can just tell them once, they will do it, and it's definitely harmless. Only thing is the volume would be required.
I wanted to try, so far not tried.
Okay.
No, but I told you that prospect study, which is a systematic review, they have categorically they said the intraperitoneal installation
is not good, I think.
Not
very effective because it's diluted, I think.
It is very much diluted and it is absorbed into the system rather than producing any effect.
Yeah.
That is the reason they said.
Yes, sir.
Even tab blocks also is the same thing.
Yeah. But then tab block gives only, sir. Tab block gives only abdominal wall analgesia. It won't give a visceral pain.
Visceral pain.
Then tab is erector spine, I think.
Yeah. So only thing is we must be deciding on the multimodal technique. So we are, just because we have got so many options, we are not going to use everything. And
As sir told,
Yeah.
laparoscopy has the same pain like this thing, open
Open.
surgery, but people think it is less painful. That surgeons induced. People think it is less painful, but actually it is painful.
Okay.
That's true. That's true.
Question is
Visceral pain remains same, madam. Visceral pain.
Yeah,
only
yeah.
vital pain is
Because
because
stretching is there.
Yeah.
Sir told no stretching. That is there. Visceral pain is there. Definitely.
any relationship?
But this pain depends on subjective, because some patients without anesthesia they recover very good and don't complain of any pain. I usually give one diclofenac at the time of induction, immediate induction, anesthesia. That takes time. But some of the patients, what you give, whatever session you give, they complain of pain because it's the patient's mentality.
Pain is definitely subjective. And the prediction of pain is also difficult.
Because whatever we give, that sedation, anything, they go on shouting that. But most of the patients do not remember. That percent is a problem because we can't manage those people. Whatever we give, they will be going on shouting and even laparoscopy. Not big, even Korea, I don't. In that other patients shout that even appendicectomy, laparoscopy, whatever we give, shout. That's the patient's subjective.
We will have such exceptions in practice also. So we do talk about in research about placebo effect. So something like this will also happen here. So despite the multimodal anesthesia, some patients could still have problem with respect to the pain perception. Sir, we have one question. Any relationship of BIS with ETCO2 in laparoscopic surgeries?
Relationship of a BIS with the ETCO2.
Sir, we are not monitoring, so we don't know.
No, it is if it is possible. No, we can monitor. That's never a problem. But the question is any relationship of the BIS with ETCO2 in laparoscopic surgeries?
No, I really don't know whether there will be any relationship, because BIS particularly, it is only the depth of anesthesia, it says, and ETCO2 may not have any influence on the depth of anesthesia as such. I really don't know. Anybody can answer that?
No, sir. I
don't think they are related actually. They may
Yeah.
not be. Madam, I doubt whether there is any relationship as such.
Yeah. So there is no direct relationship at all, because ETCO2 would, in a normal circumstance, we relate ETCO to the ventilation, and in
Are they
laparoscopy,
referring to, if they are referring to carbon dioxide narcosis or something which is a very late stage, then that may be a different one.
okay. Okay, then there is a question, sir. Your experience with supraglottic airway in laparoscopy?
Second generation supraglottic airways are quite useful, and it allows insertion of a gastric tube. So we are keeping the stomach empty, and the tube itself will hold the device in place. And all that is required is a good sealing pressure. I think definitely the ProSeal LMA and all do work. Only thing is there should not be a frequent change of position. Especially during lap chole, they will say head up position, and then they say you tilt the patient to the side. So in such situations, they're a little scary, but as such, it has not. It has got good sealing pressure. And another thing, what was described is once the intra-abdominal pressure increases, the incidence of regurgitation comes down because of the compression of the esophagus at the lower esophageal sphincter level. This has been proved by the studies. So as such, that is the incidence of regurgitation is much, much less. But by keeping the stomach empty, how far it is going to help is a different matter. But second generation supraglottic devices definitely can be used in this case. And the Busca mask is, of course, is as good as an endotracheal tube. Yeah,
that advantage is there. I think we should be waiting for evidences for Busca mask use in a large number of studies.
Yeah.
Yes. So
that's why I made the point. These are all some of the deep muscle relaxations, then use of supraglottic devices. They're all matter of study. I think it is a good occasion for our young postgraduates to take up as a study and conduct it and see for themselves how the results will be.
So we have Another senior colleagues here, Dr. Sushila Takshat. Madam, you are there, you can unmute. Any inputs for the program?
Good evening, everybody. I joined a little late, but I agree with sir that Procel LMA is like quite a good supraglottic airway for lap surgery. It works well. We are using it quite frequently.
Definitely something like, laparoscopic tubectomies and diagnostic procedures, I think we should be using it more frequently.
Yes, definitely.
They are the ones.
Madam, what about laparoscopic hysterectomies where a steep head-low position is given? You feel comfortable?
Yeah, for us, like we don't have much with hysterectomy because our team is still new with it. So there we don't use supraglottic because we know that they're going to take quite some time and they're going to move this side, that side.
Okay.
So not very hysterectomy, we don't have experience.
Yes. Thank you, madam.
Goodbye.
So I think anyway for postgraduates, again, it's a matter of discussion in Viva Voce. Even though we have almost abandoned the use of halothane, but we have our senior examiners always talking about halothane during laparoscopic procedure, vice versa, using the modern inhalation agents like isoflurane, sevoflurane, and desflurane. So I think definitely there is a greater pro-arrhythmogenic scenario in laparoscopic procedures. So that's the one thing our boys have to keep in mind. So when we talk about laparoscopy, as you said, the pneumoinsufflation with carbon dioxide. Okay, it's capno pneumo, which is used regularly. So technically and academically speaking, there is a risk of increase in the carbon dioxide in the circulating blood. There is a risk of sudden increase, which could be there also due to some mishaps of direct instillation. And if you are not ventilating properly, allowing for carbon dioxide to accumulate with possible hypoventilation. So there is always a risk of precipitation of arrhythmias with halothane more frequently as compared to other agents. So this is one of the things which is frequently asked, which is the best inhalation agent. So all these risks are more common if you talk about spontaneous ventilation, and definitely when you control ventilation also, the risk of halothane with respect to the arrhythmias is definitely not there. So controlling ventilation with a targeted, ETCO2 normally about 35 to even we can go up to 45 in laparoscopies. There is never a problem. So this risk is minimized. So this is one of the frequent questions they would keep asking. Wherever there is a discussion of arrhythmia, there would be a question about halothane. So that I think our PGs should learn and remember.
Yeah.
Actually, when I was an officer, the government projected laparoscopic tubectomies were done in millions. Actually, millions.
Yeah.
About 40 lakhs per year. And in some of the areas like Telangana, all of them are being done only under
sedation.
local. Actually, there is a Government of India circular to do it only under local with a small dose of pentagesic, and one anesthesia used to be there at the head and they used to do it at, within even 100, 150 cases used to be done in about 12 hours or something like that. And
even more, sir, more. We used to do up to 200.
And get it done. I was surprised to see that because as an anesthetist, first time I became an officer and going and seeing this ghastly thing. In our places, it is only the spinal that is being given for a tubectomy. But this laparoscopic, this one is very popular in some of the places.
Yes. No, we used to do, sir. Even I used to attend, but then pneumo was not there, and very steep head low they used to give. Very steep. So, and they used to do only banding. There was no cautery usage.
Mm.
So just hold the tube, push the band. That's
Band and
yes.
come on.
So therefore, the procedure was simple, but the discomfort was there. Patients
Yes, yes.
used to express discomfort. Sometimes we used to do up to 200 or more than 200 also a
Yes,
day
yes, yes.
in 24 hours. But no more it is a practice, sir. No government, neither government recommends nor even we are bold enough to do those things today.
Of course, we are. But it is being done even 2008 and 9 also is being done. And of course, there were specially, some of the people were specially sent to Safdarjung or some other hospital for a training.
Training, yes. So that is the reason why I made a mention in my slides. Local anesthesia was used and it is no more practiced. And they used to use this fish tank pump for creating a pneumo. Fish tank. So they were all, I think it is only for the purpose of mentioning we should do it and caution the people that that is not the method to be used.
Yes, yes.
So definitely there is more frequent usage of the supraglottic airway device. Dr. Utpal Datta has commented about use of aura gain. Yes, Dr. Parimala has talked about iGel being used. So definitely for longer procedures only, probably we should be bothered about frequent checking of the position and see that the ventilation happens without much of a problem. Dr. Utpal, you want to comment on this? You can unmute yourself. Yeah.
Thank you, sir, for giving me the chance. For laparoscopic cholecystectomy, I have used it and found it to be useful. Not always, but in some selected cases.
So you are comfortable.
These supraglottic airway devices definitely can be used for a longer duration, but the thing that is observed is because of the increased pressure that we need to use, there is a gradual distension of the stomach over a period of time. And that is being obviated by the gastric tube in the second generation tubes. So this is how the explanation is.
Even iGel is better, iGel and Baska is better.
Sir?
iGel and Baska are better.
Baska definitely, because they allow emptying of the stomach. There is a gradual distension of the stomach with every breath. That is every ventilation, the stomach gets distended. This is how the mechanism is explained. And if we can prevent that distension of the stomach, that will be good enough. Displacement is another issue. And short durations like tubectomies, yes, somebody, Dr. Parimala, short durations, definitely iGel you can use even as plain LMA also, first generation also will be good enough and they are quite convenient. We definitely agree, Dr. Parimala.
Only thing is these are more comfortably handled. The routine cases related to gynec procedures and even cholecystectomies. I think much of the problem would be there when we talk about bariatric procedures, where we have further physiology to be managed.
No, major procedures like esophagectomy or some of the bowel procedures where we are doing, the procedure is longer, 3 to 4 hours. In such situations, the hemodynamics and the respiratory physiology gets altered very much. That is where we are worried. Even the hysterectomy, lap hysterectomies, which are done normally in about 45 minutes or so, or cholecystectomy is done in 30 minutes, they normally do not pose much problem unless we are too very negligent. Only problem is, say, for example, lap esophagectomy, lap colon, that colectomies. In such cases, the issue will be there. And that is where the discussion comes. iGel is convenient. iGel with an nasogastric tube, that's what I was telling. That is a very convenient one.
So
Okay. I think any more comments from anybody?
Sir, it was very excellent.
Thank you very much, madam. Thank you.
Thank you.
Nice to
Thank
see you
all.
virtually.
So thank you very much. I think it has been very exhaustive discussion.
What about Naveen Malhotra? Is he available? It looks like he's there.
No.
Naveen?
He's busy, I think.
No, he's not. He's not able to join.
Okay.
So, sir, I think if there are no further questions, we can close the session with our gray matter becoming heavier today.
Bhaskar, did you note the earliest to answer the questions?
No, what I will do, that's why I have downloaded the chat box.
Okay, okay.
So I will exchange this with Dr. Naveen Malhotra.
No, because they should know. No,
Yeah.
they should know. They have to give their email ID. The earliest to answer will need to give a mail ID. We may not be able to make out with the names alone.
But actually, boys, many of them have left already the session.
Yeah.
Let us see what can be done, sir. Their names are mentioned. We will see how it can be tackled.
Okay. All right.
Yes, sir. So thank you very much on behalf of ISC National for having participated and dedicated time and preparation. Especially, I definitely know would have taken a lot of time to compress the whole matter into about 45 to 50 minutes of material. Thank you very much for that.
What about the next month program?
Yes, sir.
What about the next month program timetable?
Yes,
About
sir.
the lecture?
Timetable will come tomorrow, sir.
Okay, thank you.
Yeah, definitely. Tomorrow for the whole month. For the whole month.
This set of this thing completes. This particular month, the program is completed, I think, with my last.
I know very well all these things, but I am asking.
Yes, sir.
because the person mediator is changed, so let me enjoy the privilege.
Understand, sir. So, sir will not miss just like the ISACONs. He's not going to miss this also. No.
No, I can't miss the lectures, but I will miss always the ISOCON because I am not fit.
That's what I said, sir. That's what I said. You are not miss that, and you are not going to miss this also.
Yes.
So nice of you. Sayonara.
Thank you, sir. Thank you very much.
Thank you, Dr. Chakrarao, sir. Dr. Venkatagiri.
Thank you, sir.
Thank you. Then
first to fifth, we have WFSA conference, no?
Yes, sir. I think it has to start. All the
it is in hybrid mode. It is in hybrid mode or
the pure online.
Online.
Only virtual. Okay.
Purely online. So thanks to all the senior participants and the faculty from across the country and the target group, the postgraduates from different parts of India. We hope you enjoyed the academic session. So please join us every Monday evening 4 o'clock. So more is coming up for each of the subsequent weeks. Thank you very much. Good day to all of you. Long live ISA.